This is Dr. Bill Parker. I'll be showing you an abdominal myomectomy on a 49-year-old woman with a 20-week sized fibroid uterus who wished to preserve her uterus. One of the keys to getting a large fibroid uterus out through a bikini incision is to extend the incision upwards to create more room, and as you can see, then the large multifibroid uterus can be easily delivered from the abdomen. As you can see, there are multiple fibroids, pedunculated fibroid on a stalk. Now I'm looking at the normal right ovary, normal left ovary. As you can see in the still picture, in my left hand is the pedunculated fibroid, multiple other fibroids. The first step is to clamp across the blood supply to the pedunculated fibroid, and then using an electrical knife, cut through the stalk. The bleeding that you see is actually coming from the fibroid, not from the uterus at this point. And then I'll be tying off that stalk with a suture to prevent any further bleeding. First step is to then inject vasopressin. This constricts blood vessels on the uterine wall. And then to cut through the normal healthy muscle. The fibroid is made of denser tissue, mostly collagen, and so it's fairly easy to see when I get to the right surgical plane. And then I push away the normal healthy muscle. This limits blood loss because if you're in the right area, the blood supply is actually in the normal muscle away from the fibroid. And then grasp the fibroid with a clamp and continue to tease away the normal muscle away from the fibroid. In areas where the attachments are a little more dense, I can cut through that with this electrical instrument and allow me to further push away the normal muscle, again to limit the bleeding. Another key to limiting blood loss is to rapidly and carefully suture the normal healthy muscle back together again, filling up that defect where the fibroid was. I do this in 3 or 4 layers of suture and try to do it rapidly, again to limit the blood loss. We have a cell saver available for every patient. That instrument will suction blood from the incision and from the uterus and recirculate it back to the patient if it's necessary. But as you can see in this patient, there's very little bleeding, and the cell saver was not necessary. I close this area in 3 or 4 layers of a running suture to get a good reapproximation of the muscle so that I'm putting normal healthy muscle back against normal healthy muscle so that it heals properly. The last layer is reapproximating the surface tissue called the serosa to get a nice closure so that there's no bleeding and that there's very little raw space for adhesions, scar tissue to form. So this is removal of the largest fibroid, and then as you'll see in a second, the incision is closed, very little or no bleeding is seen, and it's a fairly smooth surface. The other fibroids will be removed, and then at the end of the procedure, the uterus is essentially normal size. Compare that to the uterus that we started with before the removal of 18 fibroids from this particular woman. Now I'm applying Seprafilm. This is a barrier to prevent adhesions. It will dissolve in approximately 10 days. When it's wet, as you see here, it turns to a gel immediately and protects the raw areas of the uterus from sticking to bowel or other structures in the body. And then once this is dissolved, the raw areas have already healed and the risk of adhesions is very minimal. After the sepra film is applied, then the uterus will be pushed back into the body, and then we will close this incision in a number of layers. 18 fibroids were removed from this particular woman.